from the students also. If you have any doubts, anyone can just switch on their video and ask the questions. No problem. Okay, anytime you are ready, you let me know, Vasant.
Yes, sir.
Thank you. Okay. So, good afternoon, friends. Thank you for allowing me to be part of your teaching faculty in the Gkmc alumni group. I'll be happy to share whatever knowledge we have, and then we can definitely take you further. So we'll have a presentation go in one go, and then moment she completes the presentation, then we will have question and answer session for people who are willing to ask questions, and then that's the way we go. And we'll also talk a little bit about how to manage these patients also. Okay, that is a plan for the day. Hiba, I think you can start.
Okay, sir, sure, sir. Very good afternoon to everyone present here. I'm going to present a case of scrotal swelling. A 55-year-old male, Mr. Gopal, residing in Vadapalni, who is a painter by occupation belonging to socio-economic status 4, upper lower class, came to our OPD with chief complaints of swelling in the right side of scrotum for the past 7 months. Next slide. History of presenting illness. The patient was apparently normal months back, after which he noticed a swelling in the right side of the scrotum, which was serious in onset, initially small in size, and progressed to attain the current size, not associated with any aggravating and relieving factors, no history of pain associated with the swelling, no history of trauma. Next slide. No history of sudden increase in size of the swelling, no history of loss of weight or loss of appetite, no history of fever, chills, not associated with swelling elsewhere in the body. Past history, no history of similar complaints in the past. Next slide. The patient is not a known case of diabetes, hypertension, tuberculosis, or sexually transmitted diseases. No history of previous surgeries. Personal history, the patient has normal bladder and bowel habits and consumes a mixed diet. The patient is a non-smoker and a non-alcoholic. Family history, no significant family history.
Okay, Kana, we stop here. Is this a real case or a virtual case? Now, did you happen to see this patient?
This is a virtual case, sir.
Okay, then it becomes okay. No problem. Go to the first slide now. No, not stop there. So here I will be happy to take Hiba's answer first, and then I'm also happy if someone else to contribute the answers. And if you have any questions, you can stop there. It is a sort of an informal class. I'm not going to be formally lecturing to you about anything. So students, please feel free to ask me and clarify if you have any questions then and there. Okay, fine. And this is a 55-year-old patient, according to you.
Yes,
all of us know you are working towards a diagnosis of hydrocele. So let us take that as diagnosis as a working diagnosis. Am I right? That's what Vasant said. Are you presenting a case of hydrocele?
Yes, sir.
Perfect. Okay. So what are the two common ages of someone to get an hydrocele?
Sir,
age spectrum of age, I would rather say.
Sir, when very young age and old age, sir.
Okay, what are the difference between the young hydrocele and the, in your patient, the 5th decade or 6th decade hydrocele? Is they same or they are structurally different?
No, sir, there are some differences.
Okay, what are the
young
differences?
hydrocele, it is called as a congenital hydrocele, sir, wherein the processus vaginalis is patent and it communicates with the peritoneal cavity. Whereas in a hydrocele that develops in an older person, it is just due to increased accumulation of fluid within the tunica vaginalis, sir. And the clinical features also.
No, we'll go one at a time.
Yes,
So
sir.
when you talk about persistence of patent processus vaginalis, why do you
Yes, sir.
think it is only the fluid which is coming into the scrotum and not the bowel contents?
So the opening is very small, sir. So the bowel doesn't
Excellent.
herniate, sir. Only the
Excellent,
fluid comes
excellent.
out.
So the opening is very narrow, and that is why in congenital hernias or congenital hydrocele, you allow the child to grow up till 18 months or 24 months to see whether as the child grows, the obliquity of the deep ring and superficial ring gets aligned. So there is a
Narrow.
possibility it can recover by itself. That's why in childhood hydroceles, you don't jump into it. Very good. So what is the pathology in adults? What happens in adults? You said there is a fluid communication collection in the tunica vaginalis, in the layers of the tunica vaginalis. Can you tell what are the
Sir,
layers of testes?
so the outermost layer is the tunica vaginalis. The second one is the tunica albuginea. The innermost one is the tunica vasculosa, sir.
From the skin, you say in the inguinal region, if you are going to do or layers of scrotum?
Sir, the skin, the dartos muscle, the external spermatic fascia, the cremastic fascia, the internal spermatic fascia, and then the tunica vaginalis, albuginea, and tunica vasculosa, sir.
Perfect, right. So where exactly do you think this patient will have the fluid now collected?
Sir, in the scrotal region, sir, in the tunica vaginalis, sir, in
Okay.
between
What
the
is
two
the
layers.
pathology? What is the pathology? Why these patients develop fluid collection there? Is there a minimal amount of fluid all through, or only if there is a problem, they get fluid in this layer?
No, so there will be very minimal amount of fluid, sir.
What is the function of the fluid, or what is the use of this fluid in the tunica vaginalis?
It will act as a shock absorber for the testis movements, like during walking
So
or
it allows little bit of movement and it prevents the trauma. Or it sorts of a function as a lubricant. What goes wrong to get fluid accumulation in this layer?
so either the secretion of fluid is increased or the drainage is obstructed, the lymphatic drainage is obstructed, sir, or any tumor develops and it starts secreting fluid, sir.
So if it are talking about an idiopathic hydrocele, there is some mismatch between the secretion and absorption of the fluid in this layer, or it blocks the circulation of the fluid exchange. Then when you
Yes.
talk about pathological, what are the types of hydrocele you know?
The primary hydrocele and secondary hydrocele, sir.
What is a primary? What is the secondary one?
So primary hydrocele, there is no predisposing cause for the hydrocele to develop, whereas in
Okay.
secondary hydrocele, it may be due to a tumor of the testis or an infection or lymphatic filariasis causing hydrocele.
So it is better you have a system of answering. So if you talk about secondary hydrocele, you go with congenital infection. Then of the infection, you talk about viral infections, bacterial infections. Then you go towards vascular insufficiencies like, let us talk about little later, varicocele. And then you talk about trauma, then trivial trauma to the thing. Again, it may not be directly hydrocele, it could be associated blood or associated pus. Then you go for infections, which is turning the clear fluid to dirty fluid. We'll go one by one at a point of time. And of course, in malignancy, you have blocked lymphatic channels causing on to retain fluid in the tunica vaginalis. So that completes the primary and secondary hydrocele. So now move to the next slide. So can a hydrocele be present only in scrotum or it can ascend to the groin also?
Sir, it can. The tunica vaginalis, like it can become very big and herniate through the neck. I mean, just below the neck of the scrotum and form a hydrocele end sac, sir.
So there are two types of hydrocele. One, as you rightly said, as the hydrocele grows bigger and bigger or accumulates more and more fluid in the vaginalis layer, it can appear the upper end of the sac is going on to the groin. Whereas the other second important thing is the hydrocele of the cord. So there you can have the cystic lesion limited in the root of the scrotum. But when you
Yes.
gently drag the testicles down, you will be able to very
Yeah.
clearly identify and segregate. And
Yes.
they don't reach that big size because they hardly can reach 3-4 centimeters. And usually they're very closely and intricately associated to the cord structures. Can you tell me what are the contents of the cord structures?
Sir, there are three arteries, which is the testicular artery, the artery to the vas, and the cremasteric artery, papilliform plexus of veins, lymphatic vessels, testicular sympathetic plexus, and the genital branch of genitofemoral nerve, sir.
What happened to the vast difference?
Sorry, sir, the vast difference. Sorry.
No worries, no worries. Good. In women, you have to tell about the round ligament
Round
also.
ligament,
That's
sir.
fine. Fine. Forget it. Good. You did well. So, but then if you have a system, you don't forget about it, but you did very well. Right. So, based on the contents, do these contents contribute to the development of hydrocele or a scrotal swelling?
So the papilliform plexus of veins, if it is engorged, it can give rise to a varicocele, sir.
So it is distended or grossly convoluted, it forms a varicocele. Then, right. Then, can there
It,
be filarial hydrocele or in otherwise termed chylocele?
yes, sir. Yes.
So what is the lymphatic for it to contribute? How does filarial hydrocele form?
So the organism blocks the drainage of
Is it an
inflow from
organism
the.
or a parasite?
I mean the parasite, sir. It
Oh, can you
blocks the.
name the name of the parasite?
Sir, Brugia mali and
Mhm.
Wuchereria bancrofti, sir.
Wuchereria bancrofti. Other things are less common. Fine,
Okay, sir.
perfect. So what happens when there is a parasite infection because of this?
It impedes the normal drainage of fluid from the sac, leading to increased accumulation and hydrocele, sir. And
It
invariably, it will
blocks
get
the
connected.
lymphatics. It blocks the lymphatics and then, of course, makes the sac to be increased inflammation. Can any mosquito-based infections cause this?
Sir,
Is there any other parasite which can be a contributory factor to this?
sir, Mansoni, sir.
Other rare parasites are also possible, but if you tell Wuchereria bancrofti, it's fine and good. Right. Having talked about that, now we know what is the idiopathic one. We know what are the infective ones. How does the can viral infections produce hydrocele?
Yes, sir.
What are the viral infections which can cause hydrocele?
Sir, mumps infection can cause
Very good.
acute epididymoarthritis, which can cause
What is the
hydro
mumps virus called?
paramyxovirus.
Very good, very good. So mumps virus or mumps arthritis can be again that is a secondary hydrocele. It is the inflammation of the testicles as such, but then it is a secondary hydrocele.
Okay.
So what are the other organs mumps can get affect the system apart from testicles?
So parotid salivary gland, sir,
Very good.
and
Predominantly parotid, and other things can be lymph nodes rarely. But let us not get into mumps now. Now we are talking hydrocele. Right. So that is about the viral part of it. Then what are the other causes for hydrocele? We were discussing one by one. Can trauma cause hydrocele?
yes, sir. Trauma can cause a hematocele to collect, and which may mimic a hydrocele, sir.
Okay. How do you differentiate a hematocele and hydrocele by history?
So first there'll be a trauma history,
Okay.
and the hydrocele, the fluid is amber colored, clear fluid, sir. So you'll be able to motion test.
History.
Pain associated with the swelling, sir, for
Hematocele
trauma.
need not be painful, but fine. There will be a trauma history background of can be a trivial trauma also. Yes, no problem. There will be associated pain. Then
Um, um, sir,
see, usually patient tells hydrocele patient are never bothered. If you see this big hydrocele, also patient is very comfortable. But then when there is a hematocele, patient usually says their scrotum is dragging. They are feeling very heavy. That is the most important thing.
okay,
History wise, you can differentiate. So as well,
okay, sir.
when you go on to the content-wise history, if there is a history of pyocele, right? Pyocele again has intense pain. Patient will say the pain is almost throbbing and persistently continuous. Most of the hydroceles are never painful unless there is a evidence of superadded infection. If it is a trauma, again the trauma to the testicle gives pain. Otherwise, generally hematocele does not give pain at all. They give only dragging sensation. Only when the hematocele gets superadded infection is there, then they get pain. As well, when you move on to the filarial chyle, which is present in this thing, that is also harmless. They don't give pain. But then if it is adding superadded infection, when there is active inflammation of the layers of the tunica, then you can have pain. Or otherwise, when you have trouble of handling, I would say, superadded infection to filarial hydrocele, then you have pain. Can secondary hydrocele following the malignancy can be painful? Is that a painful
Yeah.
one or not? See,
No, sir.
again, it depends on the, wait, the right answer will be, it depends on the T status of the tumor. If it is a very early tumor, half a centimeter, 1 centimeter, they generally don't give harm. But when the intratesticular pressure gets raised, or when the testicular, see, testicular capsule, the tunica albuginea is a tough fellow. It does not allow the testicles to just like that grow or get swollen. So when there is a rapid increase in size of tumor, or when there is a tumor which is stretching the tunica albuginea, very rapidly growing. What are the rapidly growing testicular tumors, you know?
Sir, an anaplastic seminoma, sir.
Very good. So anaplastic seminoma like these things or a rapidly growing testicular tumor can be painful. Then what are the other painful conditions in the testicles, you know?
So testis.
Sorry, ma?
Torsion of testis, sir.
Can you explain what is a torsion of the testis? What happens wrong or what goes wrong in that patients?
So the patients will most commonly have a bell clapper deformity, sir, wherein there's a high inversion of the
High
tunica
insertion.
vaginalis, insertion of the tunica vaginalis. So it predisposes to the testicles like turning on itself, like about the
Twisting, not turning. Twisting is the
twisting.
right word. Twisting on its
Okay.
own axis, right? That is the right way to say.
Yes,
So which age group
yes.
of these patients are more prone to get torsion?
So adolescent boys, sir.
Adolescent boys. Very good. When they grow faster, they are more prone. When they also start going into physically active thing, lot of games and other things, that could be a contributing factor. But we do not know whether there is any particular reason, or we do not have a test to identify when there is a torsion which is going to happen. So if there is, assuming you have a torsion, patient is presenting to you, what are the common findings or history the patient can tell you? Mostly the mother may say, or the child, if they are grown up child, they can say, what will be the common presenting things you will have in a torsion?
Sir,
Is it a
intense
painful
pain.
one? Yeah, intense pain, yeah.
Yes, sir. Intense pain, sir.
Then most importantly, what are the other thing patient may say?
I'm not sure,
See,
sir.
when you talk about pain, see if there is an architis, if there is a hematocele or chylocele, patient will say just holding the lifting the testicles or supporting the testicles
Relieves
gives them very good. So what happens in torsion?
Sir, torsion testis, the pain will be increased on
Very good.
supporting the testis,
So
sir.
patient will say in chylocele or pyocele or hematocele, sir, by having support to the scrotum, I'm very comfortable. But whereas in presence of torsion, there is no specific relief. Then one other thing patient may say, if you carefully ask the mother or carefully ask the child who is
Pain
presenting
is
to
so
you,
severe that he's not even able to walk, sir.
so it is an incapacitating or excruciating pain, which is present all through. And the next important thing they will tell is the testicles is pulled up to the root of the scrotum. That is a common thing, but mostly that is identified when you do a clinical examination. History wise, it is very difficult to say, but patient may say, sir, normally where my testicle used to remain in the scrotum, is missing and they are pulled up to the upper end of the scrotum. But again, this is a corroborative, not very common thing, but you should be aware of it. So then
Okay.
these are the typical presenting features of pain associated with the swelling. Now we finished the trauma. Is there any testicular swelling which starts with fever and shivers?
Sir, epididymoarthritis, sir.
Very good. So when there is association, what are the conditions or how does an epididymoarthritis form? What is the pathology of epididymoarthritis? Where from the infection get into there?
Sir, usually the patient will give a history of a UTI, previous UTI, sir, which will go by a retrograde route and cause epididymoarthritis, sir.
So that is one. Apart from that,
Um,
you can have hematological transport of infection to the cord structures also, right? And when there is an associated, apart from urinary infection, prostatic infection also can be a predisposing factor. Right.
okay,
So these things have a dramatic presentation, and filarial scrotum also can have a dramatic presentation where you have a fever with shivering onset. Here in this case, it is an insidious onset. Good. Very good. We go to the next slide. So here, what are the conditions which can produce sudden increase in size of swelling?
Sir, a testicular tumor, sir, especially
Okay.
in the
I
anaplastic
won't say it is
syndrome.
sudden, it is rapid increase. That is the right word. Suddenness, when you have an injury, when you have a trauma. So patient just before the trauma would have had a normal testicles and within few minutes they develop a huge hematoma. So they can have a sudden increase in size of swelling. What other conditions can produce sudden increase of size of swelling? So hematocele can produce. Sometimes what happens, the injury is so severe, the testicles covering itself open, rupture of the testicle happens, then spill into the scrotum also is a sudden increase in size of swelling, but those things are more uncommon. So in your case, if you say trauma gives a sudden rapid increase of swelling, or sudden increase of swelling, and then rapid increase of swelling by a rapidly growing tumor. These are the two conditions. And now as we move on to your next point, what are the conditions which produces loss of weight or appetite?
Sir, first tumor and also tuberculous epidermolysis may be associated with loss of weight, loss of appetite, sir.
Excellent. So it is a, when the tuberculosis come to the cord structures, mostly it is a systemic disease. So primarily it cannot just like they come into the cord structures. The tuberculous presence is already somewhere there in the system and then they reach to the scrotum, thus causing a tuberculous epidermolysis. More so, what is a typical type of fever in tuberculosis?
Evening rise of temperature, sir.
So evening rise of temperature or night sweats. So most of the time patient may say, I sweat a lot. I could see my cloth linen or all full of wet sweat, which could happen when I was sleeping. These are the typical things. And then loss of weight or appetite also a associated part of it. Why do you want to ask no associated swelling elsewhere in the body? What is that you want to emphasize upon?
Sir, in case we suspect testicular tumor, if it is metastasized to the lymph nodes, so we ask for any other swellings elsewhere in the body, sir.
So better we typically ask if there are swellings means I would like to ask whether the swelling is there in the neck or especially the supraclavicular fossa. This is where the typical points where you better ask there are no history of neck swellings or no left-sided neck swellings. Directly go to the point because the
Okay,
examiner, see most of the times this will be a very short case. You definitely will not be
yes.
given a hydrocele as a long case for you. So you should be very rapidly talking about important things, especially when the examiner can ask you, doctor, can you please tell what are the relevant negative points or what are the relevant negative history? Then you rattle out, I also would like to ask about the history or history suggestive of any swelling over the neck. Right. Then we move on. We move on to the past history. What is that you want to tell history of similar complaints in the past? Is there anything called recurrent hydrocele?
Sir, actually no, sir. Just
Okay, don't worry. You can have recurrent hydroceles. You can have hydrocele recurrences post-operatively. If your surgery is not done completely, what are the types of surgeries for hydrocele you know?
sir, eversion of sac, sir,
Very good.
Lord's plantation,
What is large plication? What do they do there?
Sir, it is done in case of small lax hydrocele,
Oh,
sir,
you don't do a
wherein
total eversion. You do a excision of the sac and the edges are plicated. That is large. Then third one.
excision of the sac and Sharma and Java's technique, sir.
What is Sharma?
Sir, after evacuation of the fluid from the swelling, the testis is placed in between the layers of the scrotum, sir.
Why do they want to do that? What is the principle of doing?
Sir, I don't know, sir.
So the idea is to see moment you are removing the sac, the testicle becomes exposed or the lubrication layer is not there. Technically, the idea of creating a pouch or creating a pocket of tissue in between the layers of the scrotum to keep it as to protect it. But technically, they are not needed because the belief of that operation was if you are removing the tunica vaginalis by way of one of these excision or eversion operations, the temperature control of the testicles is lost where the skin and dartos can do that, but they are really not needed. That's what is said. But then one other important point. Have you assisted a case of hydrocele, Dr. Hiba?
No, sir.
Have you seen one?
I've seen one being done, sir.
Okay,
I
fine.
was in second year.
Very good. So, if you have seen hydrocele surgery, what are the things they check after the completion? Okay, fine. We have some time to come about the operative surgery. We'll come little later. What are the other things? So, recurrent hydroceles are possible. If there are infective hydroceles, there are filarial hydroceles. If your surgery is not adequately done, we will come to the operative surgery part of it at the end of the discussion. So, it can be an inadequate or incomplete surgical operation. Right. Next. Next slide. I think
Rahul next.
someone should need to plug into this computer. I think Hiba is not holding the computer. It looks like there have been many signals telling battery is going down, plus someone should take care of it. Right. Okay. So patient is not a known case of diabetes, hypertension. So tuberculosis we discussed. Now tell a little about diabetes. How diabetes can contribute to your hypertension, hydrocele?
So diabetes is an immunocompromised state, so infection might be commonly.
So infective hydroceles are more painful. No, you already said that. Fine. As a part of it, you can tell, sir, if it is a presence of diabetes, I ask because in the perioperative care, I need to be extra careful because control of
Yes.
sugar and I expect more trouble in the perioperative care. That's what you should tell because
Okay.
diabetes is not a direct contributory
Okay, sir.
factor. Then tuberculosis we discuss. What are the sexually transmitted disease which can contribute?
So syphilis, sir, and chlamydia and gonorrhea can cause epidermolysis, sir.
Come again, ma? Syphilis?
So syphilis,
Okay.
chlamydia, and
Okay.
gonorrhea, sir.
Okay, does these things give orchitis or hydrocele?
So syphilis causes orchitis, sir, whereas chlamydia and gonorrhea cause epidermolysis, sir.
So do they produce hydrocele?
Uh, yes, sir. I'm not sure,
Only is
sir.
very rare for these three infections. I agree with that. You produce epidermolysis. Very rare for them to cause hydrocele. If you're dealing with the epidermolysis, that is very important. Here, nothing wrong, but be prepared for an answer. Not very common, sir, but they're more prone for epidermitis.
Okay,
Okay,
sir.
no history of previous surgeries. What are the previous surgeries which can cause hydrocele?
Sir, herniorrhaphy, sir. Please
How
repair.
does herniorrhaphy cause this hydrocele?
Please repair. We use a 2 proline suture and we narrow the.
What
So the.
repair, doctor?
Sorry, sir.
What repair you are talking about? After what surgery you get it?
Little's repair, sir.
What is lightest repair?
We narrow down the superficial inguinal ring using
Superficial or
4
deep ring?
prolines.
Superficial or
Sorry, sir.
deep
The
ring?
deep ring. The deep ring, sir. The
Hmm.
deep ring.
Why do you want to narrow the deep ring?